Thank you. Good morning, everybody. I know you're still coming in, but welcome to this session. I think this title should probably be more appropriately how we read cardiac CTA in our institution, and maybe more correctly how I read cardiac CTA with my fellows, because they do a tremendous amount of work. But and the reason I could say it should really more appropriately be how we read it in our center is because I'm sure a lot of you read cardiac CTA, and each of you have developed a method that works really well for you. And I think it really depends on what your environment is and what your patient population is. We do 1,800 cardiac CTs a year. 75% of our patients are from outside our institution. They are all referred from cardiology. And in the age group that we assess, about 51% do not have English as their primary language. So this determines the way we set up our practice. And if you look at the cross-section of findings, about 10% or less have absolutely normal scans. Less than 10% have significant findings that need some sort of intervention or further imaging. And then the remainder, so the vast majority of patients we see, have some sort of disease which is not hemodynamically significant, but it's not a normal scan. So I'd like to disclose that I do have research support from Toshiba Medical Systems. And I'm also going to start with the SAM. So the way they'd like us to do this is I'm going to show you this slide, read through the questions, I'll ask you to respond, and then the answer will come up. So as I'm starting the SAM sessions, I thought we'd start with a nice, gentle question as a test of memory from Sumita's talk, really. So which of the following statements best applies to CT coronary angiography? Is it 1, coronary artery dominance is defined by the vessel supplying the posterior descending artery? Is it 2, a threshold for calcium score should always be used? Is it 3, evaluation of lung images is unimportant? 4, characterization of non-calcified plaque is simple? And 5, reconstruction filters, that's image reconstruction filters, are unimportant. So if you'd press your response, and I'd be looking forward to this be a 100% correct answer. Okay, so Sumita did an excellent job, and those 5%, we can discuss that as we go along. But okay, so we've come a long way. Maybe 6 years ago, to most of us, or some of us, the whole coronary artery spectrum was a bit of a sort of a crystal ball kind of thing, and trying to figure out what that thing is, what to do with that object in the middle of the chest. But if you sit back and think about it, there are only a few or several fundamental steps that you need to do to really do a comprehensive scan. So I've tried to break it down to 12 simple steps, and these are not all of the same duration. So step 1, when I'm looking at a case, again, with my fellows or without, I will always look at the pre-scan information. We get every referring cardiologist to fill out 2-sheet form. Okay, they don't like it. They didn't like it 5 years ago. They still don't like it. But we won't do it unless we get this information. And it's patient ID, demographics, and relevant history, okay, in terms of why we're doing the study. Because that will determine our scan protocol, the length of coverage, and also the various protocols as outlined by Sean earlier, whether you use prospective, retrospective, and your scan coverage, etc. We perform our own 12-lead ECGs if we don't have one already supplied to us, and we interpret it ourselves. And also we look at the medication that the patient had. We use metoprolol orally almost exclusively, with IV to top up if required. Then I'll look at what actually happened during the scan, and as Sean pointed out, you can look at the sort of number of heartbeats you acquired, look at the exposure window and the actual phase that was acquired at the time. Now we use a wide area detector, 320, so I would say something like over 85% of our exams are done during 1 heartbeat. So that's why I don't have a fancy strip with lots of red dots on it. And this is something that all of us should be doing. We should be looking at what we've done to the patient in terms of radiation dose, every single exam, okay? Because that's the only way you know you're going to be using an appropriate technique for your patients. So I look at the KVP, the MAS we use, the exposure window, the number of heartbeats, and then the CTDI vol and the DLP. And each manufacturer produces this, and we actually send it to our packs, okay? So we can look back at this at later time. So we had this discussion earlier this morning about image data. Before I start doing a complex study, I'm going to make sure I got all the image data and that I've reconstructed everything that I need to make my analysis. So we do look at the scout views because I don't want to miss that Pancoast tumor. It's rare, but it's there. We will do the actual study on a medium field of view, but reconstruct with as full field of view that we can get, with full lung and mediastinal reconstructions. Now, I will tell you that for the longest time we were doing full lung reconstructions, and the mediastinal reconstructions were on the medium field of view, but now we're doing all three. So the lungs are reconstructed at a full field of view, as are the mediastinal reconstructions, as though we'd do for a regular CT chest, but then we're also doing the additional CT reconstructions. If you're digital on PACS, it doesn't really cost you anything, and I think if I show you this example of a case that one of my fellows read last week, here's the pancreatic mass, sort of metastasis, and if we'd just read the CT for the cardiac, we may have missed it. It's right on the edge here. And there's many examples that we've had that of similar sort of thing. Now, fortunately, or unfortunately in this case, you wouldn't have missed this mass here, but that's not always the case. So my belief is if you irradiate a part of the body with full fidelity, MA and KV, we should read it. But that's our personal field of view. So in terms of your scan technique, before I go down into drilling down into the vessels themselves, I'll check three things, the three C's. It's coverage, contrast, and compliance. So I want to make sure we have adequate coverage of the heart. So if I just orientate you on this panel here, we have the volume rendered view here. We have a sagittal, coronal, and axial view here. We have curved planar views and a luminal view, perpendicular view through the lumen here. So I will make sure that we've covered the left main coronary artery, as Sumita said, that tends to be the highest artery, and gone through the lung bases to make sure we got the PDA. But you know, coverage works both ways. If you over-irradiate the patient, okay, for every 2 centimeters that you irradiate, you either increase or decrease the dose by 12.5%. So you've got to make sure that you're not scanning 20 centimeters, for example. So I think our default field of view is about 14 centimeters, just to make sure the patient hasn't breathed inappropriately during the acquisition. The next thing is we like to see that we don't have a contrast gradient. Because we scan so quickly, and as Sean said, with a large area field of view, you can do this, you don't see a visible contrast gradient going through this scan. Then you know you've got good fidelity images. And most importantly is what the patient does, is have they breathed, have they moved, or is there an arrhythmia during the scan? Okay? So before you start analyzing things, you've got to make sure that your technique is robust. Otherwise, you're going to get in trouble and you're going to start misdiagnosing things. Then I read the non-cardiac findings, and I do this every time because A, I don't want to miss it, and B, it's a kind of message to my cardiology colleagues that these are important. That's why I put it at the beginning of the test, of the report. Now, we perform an Agatston score in every patient who's over 45 years old, and I know that not everybody does that, but I was really pleased to have this talk earlier on the calcium score, just showing what sort of risk stratification you can get from that, and our referring cardiologists really like it because they do use it. Also, it gives me some idea of what the likelihood of an interpretable angiogram is going to be. Now, we do not use a threshold of Agatston score to stop a coronary angiogram because we've had many cases now. This, for example, where the Agatston score may be 1,200, maybe 2,000, but if the calcium is distributed in thin deposits along the coronary arteries, you can still see the lumen. Conversely, we've seen people who've got an Agatston score of 200, but that calcium is circumferentially distributed around one vessel, and you really can't interpret that. So apart from the patient who gets on the table and you do a calcium score and they've got heavy proximal triple vessel calcification, we don't go on that. But otherwise, we tend to go on with the coronary angiogram because we find that it has a diagnostic purpose. We will look at the non-coronary findings, the cardiac non-coronary findings, and I find that this is equivalent to the review area in the chest. If I don't force myself to look at parts of the heart, I'll miss stuff. So this is a dramatic thing, and I know Sanjeev is going to show you some atrial abnormalities later, but here's a patient who's got an aneurysm of the interatrial septum. But more oftenly on the axial views, you'll see this, where the septum primum and the septum secundum is separated. You do a short axis oblique view through that. So here's the right atrium, the left atrium, and you'll see this oblique column of contrast jetting into the right atrium. So this patient has a patent foramen ovale. Then you'll remember to go back and look at the pulmonary artery to see if it's enlarged, to see if there's a significant flow. And you will see this up to 5% of your patients if you look. I also force myself to look at the ventricular septum because I will miss stuff. And this is a patient who had an infarct with a VSD patch, and we showed that the patch was leaking. But more often in our practice, you'll see something like this, where you'll see thickening of the anterior wall. Here in this patient with hypertrophic cardiomyopathy, we actually are a regional referral center, so we'll see this. But you'll also see other things on the Agatston score, for example, in a patient who's got coronary artery disease or symptoms of coronary artery risk factors, and here's fatty infiltration on a patient who had myocardial infarction. So it's kind of painful, but you have to look at the images you acquire, because otherwise you won't pick these things up, and it does help in your interpretation. And your cardiology colleagues will think we're all very clever, so it's all good stuff. Smita mentioned about coronary artery dominance, and this is what I'll do. I'll look at the coronary artery origins, make sure there's no anomalous coronary artery. I'll quickly look at the left main, okay? Because it'd be crazy if I spent 20 minutes struggling on whether the PDA has a 20% or 30% stenosis, and I miss the 70% stenosis of the left main, so it doesn't make sense. Quickly look at the left main, and then I'll follow the right coronary artery down, because as Smita said, it's 85% of the time it's dominant. The left is dominant in a smaller percentage, and there's co-dominance, again, in a smaller percentage. And then this is where we perform the bulk of the work, is to describe the coronary arteries. And just to orientate you again, the volume rendered view, here's a curved view that matches that. These are luminal views that center upon this dot here. So where this dot is, there's this central box here, and then this is a millimeter above and below, and these are the curved planar views of that vessel. So without becoming too loquacious, we'll describe the arteries with their origin, the caliber, length, and branches. So for example, you might say the right coronary artery is a good caliber vessel with a single acute marginal branch, a long good caliber PDA, and a short posterolateral artery. That's it. And then go on to discuss if there's any disease. And this is a patient that actually we scanned last week who was unfortunate enough to be able to help us in demonstrating how I would grade different levels of disease. So in this particular patient, in the left main coronary artery, as you can see here, it's nice and clean. The contrast column fills the lumen. There's no soft tissue to that at all. So this would be a patient who's no disease at all. And for some of you, you may decide that all you're going to describe, and it's a valid point, is to say CT is used for no disease, disease, or I can't tell. And if you do that, you're going to be right most of the time. But I would say to you that I think we're a bit better than that. But equally, I don't belong to the camp which will say this is 5% or 10%, 10% or 15%. I don't think we're that good. And you have to decide how you're going to approach this, but this is how we do it. So no disease. If you see a little bit of something, that shouldn't be there. So there's the lumen, and you have this little trace of soft tissue. Then we describe that as less than 30% luminal stenosis, and we compare it with normal segments either above and below whatever we have. Okay. Some say it's less than 10%, some will say it's less than 50%. It really depends on how you do this, but we use it as less than 30%. And then the next category we have is 30 to 49%. And here you have a patient who's got some calcified plaque, a little bit of soft plaque, also non-calcified plaque, I should say. And this is more than 30% when we measured it and when we looked at it, but not more than 50%. And that's another point I'd like to mention. The manufacturers have many, many tools you can use to measure stenosis, whether you use area or cross-section. And you can change the threshold on those tools to make the measurement whatever you want it to be. So I would very strongly recommend to you that you make your mind up before you do a measurement, and then you validate it with the measurement. If you do it the other way around, you're going to have some very bizarre findings, which even when you step back and look back retrospectively, you're not going to agree with. Okay? So look at it, make your own mind up first, and then use a measurement to validate it. The next category is someone who's got 50 to 70% disease, and you can see, again, same patient. Here's the lumen with contrast, here's non-calcified plaque, and here's this eccentric calcified plaque. So this is, we're getting in the category now, the cardiologists are now starting to get interested in this patient. In patients who you see very little contrast, but you can persuade yourself to see a dot, or the extent, linear extent of the abnormality is less than a centimeter, chances are it's between 70% and 99%. Okay? That's different from the patient who has this appearance. So we had some arrhythmia and breathing issues here, but even so, you can see the right coronary artery has no contrast for about 2 centimeters. And if you see that, no contrast for at least a centimeter or so, you're going to be pretty confident and accurate if you say this is occluded. Clearly in CT, what we don't see is all the little collateral vessels and the retrograde filling, etc. So that's the way that we describe luminal disease. What you can't do is see through calcium yet. okay? So if I see this, a whole blob of calcium, I don't guess, because clearly you'll only be right 50% of the time. And equally, if I try to drill down in non-calcified plaque, and we try to be, is it lipid-rich, fibrous, or mixed, you may be right by statistical chance, but you're not going to be right most of the time, because the spatial resolution of our scanners is not yet good enough to robustly differentiate between the different types of non-calcified plaque. So if you get to the stage where you're saying it's calcified and non-calcified and get a luminal assessment, I think you're doing pretty well. And then, very important, conclusion. And for my view, the conclusion should not be a reiteration of what you've already said in the report. It's got to be, what do you think is going on? And the conclusion will be there's no coronary artery disease, so you have a normal system. It could be that there's no hemodynamically significant lesion, so the patient will probably have medical therapy and some lifestyle adjustments. Or it could be that there's a radiologically hemodynamically significant disease, and although we don't talk about revascularization, the patient will tend to go on in our center to have further assessment of that coronary artery, usually with angiography and with consideration of stenting or bypass grafts, depending on the extent of their disease. And in terms of stents, as Sean mentioned, I'm not a big fan of CT for stents. We still have issues if the stent is bigger than 3 millimeters, if it's heavy metal construction, and if it's in a distal vessel. I don't feel that I can reliably tell whether there's in-stent stenosis or not. And we get lucky sometimes, and we can, but not on a reliable basis. Now, we do less and less of functional assessment, and the reason for this is we do a prospective technique, very short exposure window. But in the days when we did do a full cardiac retrospective analysis, we would do this routinely to look at ventricular volumes, ejection fraction, and wall motion analysis. And almost exclusively now, the patients we do this for is our congenital heart patients who can't have MR for one reason or another, and they need to know about the right ventricular volumes, because echo is pretty good for the left, but not so good for the right. And this is where it all happens, the report. Now, I know as cardiothoracic radiologists, we're a creative bunch, right? But, we're not Shakespeare, and we don't need to be. And I would stress upon you that if we could have some sort of standardized reporting or some concise terminology, and a one-page report is usually all you really need. And I would put to you that ideally we should focus on something like this guy would say and really be very factual about it. And you could have some sort of creative prose at the end, because nobody's going to read through a 3-page scan. You know what your colleagues will do. They go right to the end, and they say, what did you say? Okay? And if your report is the coronary arteries I can't assess, but there's lots of indeterminate lung nodules, they're not going to be happy with you, right? So I think we have to really understand what the message goes out to the referring physicians. So in summary, I've broken it down to 12 steps. You may have 4, you may have 5, or whatever, but in our institution, this works in our setup very, very well. And we try to keep these steps going because we are a training center like many of you are, and it helps the fellows that come in to understand what the thing is. So with that, I'd like to thank you very much for your attention.
Coronary CTA is increasingly utilized mainly for low and medium risk patients for coronary atherosclerosis. It is also a problem solver for people who've had echocardiography or conventional angiography, where the cardiologist can't make out what they're seeing anatomically, and then they go towards coronary CTA. So it's having an increasing role in radiology. Coronary diseases can also be diagnosed on routine non-cardiac CT, where there is no EKG gating. So it's good to know what the disease patterns could be and to have a pattern-based approach. Here's a patient who came to the emergency department, a 37-year-old woman with chest pain, history of smoking, and obesity. You can see on the axial image here that there was non-opacification of the proximal left anterior descending coronary artery on this non-gated study. But when you look at the heart and they look at the myocardium, there's hypoperfusion of the septum apex and the lateral wall, which suddenly stops at that location. And on the 2-chamber short axis view, similar hyperperfusion is seen which has a sudden stop. This shows a hyperperfusion in the distribution of left anterior descending coronary artery diagnosed on a non-EKG gated CT, and this patient had a cath, and it turned out to be acute thrombosis of that left anterior descending coronary artery. So the objectives of our talk are three here. The first one is to provide a practical approach and list of differential diagnoses for various patterns. And I'm going to base this on the effect of the disease on the lumen and the wall, try to describe the findings to help diagnose specific disease, and discuss practical tips of how to differentiate these various diseases. So I've arbitrarily divided them into four categories: what causes focal or segmental narrowing of the lumen, focal widening or aneurysms, diffuse narrowing, and what causes diffuse widening, or in other words, ectasia. That has been further divided into ectasia with tortuosity and that without tortuosity. So causes of focal or segmental narrowing could have a long list of atherosclerotic plaque, myocardial bridge, and pseudostenosis. These are the ones that you're most commonly are going to see. But the more rare ones are coronary artery dissection, anomalous intra-arterial course of a coronary artery, external compression or mass effect, and peri-aortic fibrosis. Dr. Paul has already covered this, but when we have an atherosclerotic plaque, we describe by location, plaque composition, and degree of stenosis. And I'm going to show you an example here of a patient who had a lesion here in the right coronary artery, right at the location of the branching, where you can see that the wall of the vessel comes in a little bit, and this is described to be negative remodeling. Here's a different patient in the left anterior descending coronary artery. When you blow it up, you can see that there's a plaque inside the vessel. There's again a slight inward curvature of the outer wall. This is also described as negative remodeling. So when you see that with severe atherosclerotic disease, and there may be reconstitution of flow distally by collaterals. You usually have this when there is a chronic ischemia. If the patient has total occlusion in an acute setting, that's usually in the setting of an acute coronary event. So negative remodeling, you have a narrowed lumen, no outer wall expansion, and you may have a wall contraction, which for instance here, there is a patient who has a long segment of mixed plaque here in the proximal left anterior descending coronary artery. Hard to see the lumen well because of the calcified plaque. When you see the angiography, there are definite areas of stenosis shown by the yellow and red arrows. Here's a different patient, which I actually read in real life, and you can see in the left anterior descending coronary artery, there was a focus here where again the lumen becomes inward. Because there was good opacification distally, I wasn't sure I was going to call that. I looked at the cross images of it, and it does look like the lumen becomes narrowed as well. So you wonder, is this negative remodeling? Why is there good flow distally? This patient did have a cath. Here's the first set of images. You can see the lumen is significantly narrowed, what you see with negative remodeling, but again, there's distal flow. A little bit image taken a little bit later, you start seeing better opacification. The stenosis becomes a little bit more obvious, and you can see here, with a more later image, there are many slightly dilated and tortuous vessels that are providing flow to the diagonals on left anterior descending coronary artery, causing that distal opacification. These are based on patients who have chronic ischemia, and then they have the collateral flow. Since our imaging is fast and we don't have these subsequent images, we're not very good in seeing the collateral flow. But what we do see is the distal opacification, and that's what you're going to be a sign that despite the severe stenosis, the good opacification distally will raise the thought that there is collateral flow there. Another cause for focal narrowing could be myocardial bridging. This is most common in mid-left anterior descending coronary artery. It's usually of no clinical significance. The vessel dives into the muscle and then reemerges, such that on the image on the right, you can see that the vessel here, even though it gets narrowed, usually the patients are asymptomatic, and you can see it's surrounded by muscle here, and later on it reemerges again in the fat. Pseudostenosis can be caused by artifacts, most commonly by arrhythmias, non-gating of the R wave, chest wall motion, or beam hardening artifact. And how can you tell if this is an artifact or not? Well, one way to do that is to look at other reformatted images. When you do that, you either look for resolution of that stenosis or look for stair-step artifact. Both of those are signs of the artifactual nature of that finding. Sometimes EKG editing is needed to resolve that stenosis. So here's a patient, left anterior descending coronary artery, 2 areas of focal stenosis here. We looked at the curved MPR image. This stenosis resolves. There's a slight stair-step artifact here, which tells us that was not real. Here's another patient in the right coronary artery. You can see there's a circumferential focal narrowing. When you look at the cross images here, it does look like it's real. It gets narrowed down there. And this is where you have to make sure that you don't get fooled by your software, but rather you do go and check your other coronal and sagittal images, and there's definite stair-step artifact here. This is definitely artifactual. You can see that same here with this ribbon view where it has a nice shift there. So this is pseudostenosis. This is another patient where there were 2 lesions seen in left anterior descending. When you look on the coronal image, on the 2-chamber long axis view image of the left anterior descending, it persists there. Makes you wonder, is that real? There is no stair-step artifact. This is not a breathing or motion artifact. Looking at the EKG strip, this patient did have arrhythmias with some PVCs. And when that was edited, you can see that those lesions resolved. So a study that you could describe as limited or misdiagnosed stenosis could be, with EKG editing, get salvaged, and you can show that the lesion is not real. Beam hardening artifact, when you're looking on the axial images, could look like a non-calcified plaque. Usually that is easy to identify because it has a typical look. You can find the metallic structure and has the linear photopenic rays. Now, getting to the less common causes of focal narrowing, one is coronary dissection. If you see it, it's most commonly in the setting of aortic dissection, where the aortic dissection is a type A dissection and extends into the origins of the coronary arteries. It could be seen iatrogenically when patients when they have selective coronary artery angiography, or spontaneously in patients with Marfan or Louis Dietz. Anomalous coronary arteries, when they have an interarterial course, it could undergo narrowing because of external compression between the aorta and main pulmonary artery. This can cause ischemia, but this is not the only mechanism. The orifice can become stenotic, or the proximal course can become narrowed because the intramural nature within the aortic wall. And the other thing to know is that even though these are young patients, they can get premature atherosclerosis because now the vessel has an abnormal course, and the branches are going to come off at weird or 90-degree angles, and the turbulent flow could cause premature atherosclerosis. So here's a patient. You can see a vessel coursing between the 2 main vessels. It branches into left anterior descending and circumflex, so this is the left main coronary artery. When the red arrow here is showing the pulmonic valve, and the vessel, you can see, is above that, between the aorta and the pulmonary artery, so that is definitely an interarterial course. And when you create an oblique image along the course of the artery, you can see that it has become narrowed, and its origin has a 90-degree or almost 180-degree turn here, which makes this patient more prone to ischemia. This is a patient with anomalous right coronary artery. The image to the upper left shows that the vessel is coming in between the aorta and the pulmonary artery. It's again above the level of the pulmonic valve, so you go, oh my God, this is another interarterial course. Look at the coronal image, again, it's doing the same thing. You have to realize when there's a patient who comes with an incidental finding of anomalous right coronary artery, it's not always physiologically compromised. So if it's an older patient who comes with that, I either recommend a stress test. In this case, the patient had an angiography, and you can see that, yes, it does have an anomalous course, but it's not necessarily narrowed. Here's another patient here, again, anomalous right coronary artery. It does look slit-like here, makes you even more worried. This patient did have a stress test. You can see that there's lower septal and inferior wall reversible perfusion on stress and rest. This is where the RCA is feeding. So this was a case of anomalous RCA causing ischemia. A rare cause of narrowing could be by external compression by a dilated pulmonary artery, either because of pulmonary hypertension or rarely from pulmonary aneurysms. Here's a patient here where we can see this patient has severe pulmonary hypertension. Here's the main PA, and the left main coronary artery is becoming compressed close to its origin. Rarely the coronary arteries can become involved by some sort of fibrotic process, either in the setting of a vasculitis or because of some sort of fibrotic process occurring in the mediastinum. This is a 71-year-old male who had retroperitoneal fibrosis, had a lot of inflammation of the aorta going down into the abdominal aorta, and you can see that the wall is thickened. On a non-enhanced study, it's somewhat calcified. And when the patient had a coronary CTA, there were some areas where you can see the coronary arteries surrounded by the fibrotic tissue causing focal stenosis. Now moving on to the causes of focal widening or aneurysms. So there's a list of various causes, and I'm going to try to go through them one by one. Congenital aneurysms are very rare. They're described in the literature, but it's hard to prove if something's congenital or not. One thing that could help you is to think that to see if there's atherosclerosis or calcification. If there isn't any, that's one thing to think of, but it's usually a diagnosis of exclusion. Positive remodeling of atherosclerotic plaque, on the other hand, is something that you will commonly see. What happens is that the outer wall of the vessel expands in the presence of plaque. So here, a lesion in the proximal left main coronary artery, you can see that the outer wall is expanding. It does cause some luminal narrowing, but this outer wall expansion is a sign of positive remodeling. This is another patient here who has diffuse disease. Here it's hard to see the vessel lumen because of the calcification, but the rest of the vessel also has atherosclerotic disease, which we see better than angiography, because when the patient had a coronary angiography, that looks completely wide open. Here's another patient, 62-year-old or 47-year-old man with equivocal stress tests and elevated cholesterol, and you can see that there is no significant luminal narrowing despite the presence of plaque. So you wonder, why care about positive remodeling? Well, one reason is to know in general is CTA and endovascular ultrasound is better, or they're both better in diagnosing positive remodeling. And this could allow a better appreciation of the plaque burden, which can cause earlier initiation of lipid-reducing medicines. Cardiologists need us to report this even if there is no stenosis. And these lesions are associated with an increased risk of acute coronary events. So again, it's important to report these studies, these findings of a positive remodeling. And why is that? Because there's inflammation at the plaque margins, which can undergo ulceration, thrombosis, and sudden complete occlusion, which is equivalent of an acute coronary event. How can we talk about, I'm going to put in here, what plaque characterizations are associated with an acute coronary event? These are determined by endovascular ultrasound, and they are a lipid core that has an attenuation less than 50 Hounsfield units, scattered or dotty type of calcification within the plaque, a thin fibrous cap on the plaque, and positive remodeling. Now I have to say, of all of these things, the lipid core, the scattered calcification, the thin fibrous cap, we don't have the temporal and spatial resolution to truly diagnose that and to confidently report that, despite all the what the software shows that it can do. The only one that we can confidently report is positive remodeling, and we do have the upper hand over coronary angiography in reporting that. So this is why it's of importance. Atherosclerotic aneurysms